Um, Hi, everybody, again. Thank you for the Neurosurgical TV for such opportunity, and thank you for Professor Ayub for giving us sharing different experience from different parts of the world, especially regarding the trauma. And today topic, I'm Samar Hoz from Iraq, and today topic will be a blast-induced traumatic brain injury, a peculiar type of brain injury, and maybe have a different characteristic and different management strategies. It's not about options, it's about the strategies. So I will take approximately less than 10 minutes describing giving an overview about this specific type of brain injury. I have no conflict of interest, and I always start my presentation with this slide. Um, we are not in ourselves superior to our father, and we are shamefully inferior to them if we do not advance beyond them. Many mentors from different parts of the world. I think there is something on the screen, uh, John. Okay, so a blast-induced traumatic brain injury, it's mainly related to a car bombing causing a head injury, causing a various scale of head injury. I think Iraq, one of the hottest spots in the world regarding such type of injury because of the war against terrorism. And according to our review, that Baghdad, which is the capital of Iraq, witnessed the highest number of bombing attack as per city in the world, maybe in Afghanistan or Pakistan, a comparable rate, but I think Baghdad, as per blast-related injury, it's the hottest spot and the which is unfortunately and the highest number of bombing occur in Baghdad, which is our city and the capital of Iraq. So, in general, I want to highlight the damage control neurosurgery, which is a nice concept in neurosurgery, specifically related to trauma. We usually hear about damage control surgery that's applicable for the general surgery, but here, damage control neurosurgery, a tailored triaging system. I will describe. We use it for such mass trauma, and we always need alter the standard while facing such disaster, and if there is a future perspective regarding the blast related traumatic brain injury. So as introduction, I will give some numbers, and yes, it's maybe a frightening number that in recent decade there is tenfold spike in terroristic activity over the world, and specifically for the blast previously was used in the military setting, but now 60% related to terroristic attack. So mainly we are discussing a civilian injury rather than the expected military. That's a main difference here, that these blast injuries targeting civilian people, those unexpecting or not protecting themselves, that will cause a mass casualty, overwhelm even the most sophisticated health care system. That's why we are sharing our experience. Um, and what we mean by car bombing, scientifically we call it vehicle-borne improvised explosive device, and the quantities may be held within the car, may reach up to 3,000 kg, and in Iraq specifically from 2003 up to now, more than 20,000 explosions, 1,600 suicidal attack, mainly by blast, killing more than 100,000 people, and wounding the wounded population is much more of that number. That's sadly a gruesome injury. And in 2009 specifically, which is the year that we make the study in it, there is more than 800 explosion and suicidal attack, including 82 vehicle-borne improvised explosive device. I mean, blasts related to car bombing, and this eventually killing more than 4,000 civilians. That's how severe the injury is, how focus this type of this mechanism of head injury should take care of it. So in general, as per ballistics and mechanism, the blast-related injury include a primary type of injury or a primary wave, which is the direct, then the secondary, where the other particle or missile hits the victim, and finally the tertiary, when the victim fall or stuck by other stuff. And even some article added a quaternary blast injury, which is related to heat and chemicals. That's the mechanism of the blast injury and how it hurt the body. And from that point, we go and start to document this injury, because in Iraq, as most of the let's say undeveloped country or developing countries, as per healthcare system, we have no real documentation, no real systemic documentation. So we start so the documentation is already one of the toughest job while doing such studies. So we are happy to finally publish this article at the titled "The Blast-Induced Traumatic Brain Injury Experience from the Deadliest Suicidal Double Car Bomb Attack in Iraq." This is study done by Iraqi neurosurgeon practicing in neurosurgery teaching hospital, and with the support of our resident aspire to be a neurosurgeon, Zahra Sharshahi, which is a very brilliant um, uh, um, person, help us to document and to share our experience with the world, and also with the supervision of Dr. Ali Biden from John Hopkins, Maryland, USA. So the incident we are talking about is occurred in 2009 near in the center of Baghdad, involving two suicidal truck bomb that with an interval of like 10 or 15 minutes between the two bombs that will result eventually in more than in 152 deaths, and I think more than this number, but the documented number of injured people is 520, which is very deadly regarding morbidity and mortality resulting from this attack. The setting is the neurosurgery teaching hospital, and we analyze the patient according to all the possible parameters. And this is the summary of our study that in the neurosurgery teaching hospital, we received 75 patients. You can imagine, that these patients were all received at the same time in a tertiary center for neurosurgery. So it's a very high number. And from the 75, 19 died directly or immediately in the emergency department, 56 admitted to the hospital. From that number, 39% go direct or patient go direct to the surgery, and the other treated conservatively either in the neuro ICU or in the ward. As per Glasgow outcome scale at the discharge, eventually 17 dead from the admitted patient, and the other between good and poor outcome. In general, it's a poor outcome for such type of injuries, but let's take it from the neurosurgical point of view or from the management point of view, that doing 39 surgeries for patients coming at the same time, this is a huge number, and actually it takes 4 days, 24 over 24, with the three operating room working in parallel to manage such um, number of patients. That's the general idea of how we manage this patient. As per statistic, we analyze all the possible parameters with the patient regarding imaging or associated injuries, and also management and outcome. Specifically regarding the management, we took a step further. While usually such injuries described are decompressive craniotomy, we dig in the details and divided it into hemicraniotomy or bilateral frontotemporal craniotomy or posterior fossa craniotomy, and compare it with other factor to ask for the significance or the difference between these treatment options. Also regarding cortisectomy, while dealing with the wounds, sometimes there is a brain tissue injured. Either you can do localized cortisectomy, or sometimes you are obligated to perform frontal lobectomy or even temporal lobectomy. These factors studied in detail, and this is in our study. And even for we perform subgroup analysis comparing Glasgow below and above 8, pupil normal versus abnormal, according single versus multiple shell injury, single versus multiple lobe injury, and even intact or injured dural venous sinus. Also, we add I think, a new factor if the patient has a brain tissue out from the wound at the reception in the OR or not, and how it affects the prognosis. This specific point, I will talk about it later. But statistically, these subgroup analysis give no significant difference, but give a comparable, and that one of the expected result from such random injuries. As I said before, the damage control neurosurgery, it's not very well discussed in all the study, but here we are focusing, comparing it to the standard surgery. It's a difference in the speed and efficacy of operating room rather than a difference in the nature of the specific surgery. The damage control neurosurgery, we mean by it to elevate the depressive fracture, removal of shell or accessible bone, hematoma evacuation, cleaning and debridement, hemostasis, dural repair, and then wound repair. That's in total called, we call it the damage control neurosurgery. This means that doing the most urgent thing only, and leave time-consuming steps for a later surgery. That's the idea. I think as per management, we put it in this context. In hospital, 4-level triaging approach, while receiving the patients, the first stage occur in the emergency department, 2 neurosurgeon and 4 resident receiving the patient and doing a primary survey according to ATLS, then all the patient referred to the level 2. Level 2 is occur near the CT scan in the radiology department. 2 radiologists involved with a neurosurgeon, so he can take the decision at the CT scan while doing the CT scans for the patient one by one. And from this, from the radiology unit, either the neurosurgeon decide to transfer this patient to the nearest hospital if there is polytrauma and need other specific treatment rather than neurosurgery, or refer to the next levels, either direct to the ER or direct to the ER or to the neuro ICU. Level 3 in the neuro ICU, 2 anesthetists, 1 neurosurgeon, and 2 residents. Those with a Glasgow less than 8 or need stabilization and preparation for surgery, or not candidate for surgery but need ICU maybe for respiratory care. All these are admitted to level 3. And level 4, it's a 3 trauma neurosurgery ORs where in operation at the same time, each with a neurosurgeon and resident working together. And it take, as I said, 4 days to finish the 39 surgeries. That's the real challenge. And this maybe for practicing in neurosurgeon, they know the difficulty while managing 39 at the same time is the prioritization. Some sample of blast-related injuries that we receive or we expected from the CT scan. These are the findings, examples of the finding. Also, sometimes you find a large shell from part of a car sticking in the head of the patient. All are severe injury and gruesome. As I said, I will return to the brain tissue out point. Sometimes in the emergency department, the patient came with the brain, came out from the wound, and this will be inside the operation and require cortisectomy. Sure, any brain tissue external to the skull, this is mainly non-functional tissue. And specifically regarding this point, that traumatic acute, we call it brain tissue out, call it, or traumatic acute extracranial cerebral herniation, we found very few talks about it in the literature. So we explore it into another article in the form of letter to editor, asking about how much do we know about this type of, or this parameter of injury. That's in general, that's the idea that I want to give about the blast related. It's just, I can just give an overview. I invite you to read our published article, because it contained all the details. You know from this presentation that more details for each step can be discussed. And yes, that's the type of trauma that we are dealing with it here in this part of the world. And also, maybe in a later presentation, we can discuss total different type of trauma. It's caused by tear gas canister, which proposed to be a safe um, 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 issue, but in Iraq, in the final, in the last year protest, we receive such type of injuries. All are tear gas bomb penetrating the skull, and yes, I think for a neurosurgeon, it's rare imaging how this canister enter inside the skull, and for sure it's mostly deadly. And you can think that this patient came alive to the OR, to the emergency department, and thus require CT scan, and a lot of patients do not reach the emergency department already. All of the work, and I think from the tier system or the triaging system, we propose that managing trauma or massive trauma definitely require a team and a synchronized team to give the best result for the patient. And thank you. I'm ready for any question if you want.
Okay,